In this video, we are going to discuss the recall anatomy questions discussion of NEET PG 2022. Okay, fine. Let's move to the first question. A vascular surgeon has performed varicose vein surgery. Post-operatively, the patient has developed loss of sensation on the medial side of leg. Which nerve most likely injured in this case? So what is the answer? Yes, the answer is Safinas nerve. Okay, this is actually a repeated question. Just one year back, this question has been asked. Okay, in PG exam only, PG entrance exam. Okay, so the answer is Safinas nerve. Okay, so during the surgical removal of the varicose long saphenous vein, okay, or great saphenous vein, the saphenous nerve may easily get injured because the long saphenous vein or great saphenous vein is closely accompanied by saphenous nerve, isn't it? By saphenous nerve. Okay, so you can see the saphenous nerve runs just in front of medial malleolus. Okay, it runs just in front of medial malleolus at the level of ankle joint. Okay, and not only saphenous nerve, both are closely accompanying, isn't it? The long saphenous vein and saphenous nerve both are running just in front of medial malleolus of the ankle joint. Okay, and remember, this saphenous nerve is a branch of femoral nerve. Okay, saphenous nerve is a branch of femoral nerve. And what is the importance of the saphenous nerve? As you see in this diagram is showing the cutaneous innervation of dorsum of foot. Cutaneous innervation of dorsum of foot. Okay, so the sensory supply of dorsum of foot is by 4 nerves. Okay, so the nerve I am marking now is the superficial peroneal nerve. Okay, so as you see this diagram, the superficial peroneal nerve will divide into 2 branches, and this is the main nerve. This is the main nerve of dorsum of foot. That means the major part of the skin of dorsum of foot is supplied by the branches of superficial peroneal nerve, isn't it? So this is the main nerve. And right now I am marking another nerve supplying the skin of the first interdigital cleft, isn't it? What is this nerve? Yes, this is the deep peroneal nerve. Okay, the nerve I have marked is deep peroneal nerve, which supplies the skin of first web space. Otherwise, we can say the skin of first interdigital cleft. Interdigital cleft. That is the gap between the great toe and second toe, isn't it? Fine. And what are the 2 more nerves you are seeing here? The nerve I am marking now is the saphenous nerve, which is closely accompanying the long saphenous vein, isn't it? Or great saphenous vein, whatever. The saphenous vein, we know it supplies the medial side of leg as the history case scenario given. Okay, so the saphenous nerve supplies the medial side of leg as well as medial side of dorsum of foot. As you see here, this particular area, medial side of dorsum of foot, medial border or medial side of dorsum of foot. Okay, and what about the lateral side of the dorsum of the foot? Yes, it is supplied by one nerve called as sural nerve. Sural nerve, isn't it? Sural nerve supplies the skin of lateral side of foot, lateral border or lateral side of dorsum of foot. Okay, and we have to keep in mind the sural nerve. Okay, the sural nerve is a branch of tibial nerve. Sural nerve is a branch of tibial nerve, and this sural nerve closely accompanies short saphenous vein. Saphenous nerve, you know, it is a branch of femoral nerve. And it closely accompanies long saphenous vein or great saphenous vein. Okay. And the sural nerve is a branch of tibial nerve. It accompanies short saphenous vein. Okay. Fine. So these are the things we have to remember regarding the cutaneous innervation of dorsum of foot. So this can be a image based question. Okay. That can be asked. Okay. In future exams, they may be marking the image based. This particular area may be marked, and what is the nerve supply for the particular area, that is deep peroneal nerve. Okay, fine. So the answer for this question is saphenous nerve. Okay, and we have discussed the areas of the dorsum of foot supplied by the other nerves: superficial peroneal nerve, deep peroneal nerve, and sural nerve. Okay, yes. And one more thing I want you to know: common peroneal nerve. Okay, common peroneal nerve is the one which terminates into superficial peroneal nerve and the deep peroneal nerve. Okay, at the level of what is the bony landmark where the common peroneal nerve divides into superficial and deep peroneal nerve? Yes, neck of fibula, at the level of neck of fibula. Okay, so obviously if there is fracture of neck of fibula, it will result in injury to the common peroneal nerve. So both the terminal branches of the common peroneal nerve will get damaged, resulting in one clinical condition, deformity called as, yes, foot drop, isn't it? Foot drop deformity, isn't it? Okay, fine. Let's move to the next question. One histological image has been given like this. Okay, so identify the given histological image. Okay, so can you tell me what cartilage has been given? Yes, the answer is fibrocartilage. Okay, so can you tell me how to identify the slide of fibrocartilage, hyaline cartilage, elastic cartilage, and all? So see this diagram. Yes, this is the fibrocartilage. So the identification point for the slide of fibrocartilage, you know, the outer covering of the cartilage is called as perichondrium. Okay, so perichondrium is absent in fibrocartilage. Okay, perichondrium is absent. Perichondrium is present in hyaline cartilage and elastic cartilage, but not in fibro. So fibrocartilage, perichondrium is absent, no perichondrium. Okay, and can you see the chondrocytes? All those blue colored structures. Okay, they are chondrocytes, and the chondrocytes are arranged in rows. They are arranged in rows in between the bundles of collagen fibers. Okay, these are the two identification points for the fibrocartilage. Okay, one is no perichondrium in fibrocartilage. Another one is chondrocytes are arranged in rows in between the bundles of collagen fibers. Okay, and what is the main type of collagen fibers present in fibrocartilage? Type 1 and type 2 both, but mainly type 1 collagen fibers. Okay, fine. Now let's discuss how to identify the histological image of hyaline cartilage and elastic cartilage. Okay, actually this is the image of hyaline cartilage. How to identify? Yes, this is the perichondrium. Okay, are you able to see the perichondrium, the outer covering of the cartilage? Yes. Now the main point for identification of hyaline cartilage is basophilic homogeneous matrix. Can you see the blue colored structure within the substance of hyaline cartilage? So the hyaline cartilage can be easily identified by the staining nature, that is basophilic homogeneous matrix. Okay, basophilic homogeneous matrix. So the matrix will be appearing bluish color. Okay, that is one of the identification points. And the chondrocytes are arranged in groups. Okay, chondrocytes are arranged in groups which are called as cell nests. Okay, chondrocytes are arranged in groups called as cell nests. Okay, and hyaline cartilage contains what type of collagen fibers? Type 2 collagen fibers. Fibrocartilage type 1. Okay, hyaline cartilage type 2 collagen fibers. Is it fine? Yes, let's move to the histological slide of elastic cartilage. This is the slide of elastic cartilage. And how will you identify the slide of elastic cartilage? Yes. Do you see the perichondrium here? Both sides, perichondrium, outer covering. Okay, fine. So the elastic cartilage can be identified by the size of the chondrocytes. Okay, so compared to the chondrocytes of hyaline cartilage, the elastic cartilage, the chondrocytes are larger. Chondrocytes are larger. Okay, and obviously the elastic cartilage will be having abundance of what? Elastic fibers. Abundance of elastic fibers, more elastic fibers, and the collagen fibers also will be there. What type of collagen fibers? Type 1 or type 2? Type 2 collagen fibers. Similar to the hyaline cartilage, the elastic cartilage also contains type 2 collagen fibers. Okay. So, and what is the nature of the matrix? Yes, it is eosinophilic. It is appearing as pink, isn't it? But we have studied in hyaline cartilage, it is basophilic matrix. Okay, but elastic cartilage contains eosinophilic, that is pink colored matrix, right? So these are the points for identifying the slides of hyaline cartilage, elastic cartilage, and fibrocartilage. Right? So the slide is showing the comparison of the three types of cartilage. Okay, and you know the fibrocartilage can be otherwise called as white fibrocartilage. Fibrocartilage is called as white fibrocartilage, and the elastic cartilage is called as yellow elastic cartilage. Fine. So we have discussed how to identify the slides of all the three types of cartilage. Now I want you to know what are the locations of the various types of cartilage. Okay, so I request you to go through this slide to know the various locations. Hyaline cartilage is present in majority of the parts of our body. Okay, so the costal cartilages, nasal cartilages, larynx, trachea, bronchi, then epiphyseal plate, then articular cartilages. Okay, all are made up of fetal skeleton, all are made up of hyaline cartilage only. Okay, fine. Elastic cartilage, the three classical examples for elastic cartilage can be remembered as 3 E's. Okay, one is external ear. External ear means that is one is auricle, another one is external auditory meatus, isn't it? Another one is epiglottis, another one is Eustachian tube, otherwise called as auditory tube. These are the three classical examples for elastic cartilage. All will start with E. External ear, that is auricle, otherwise called as pinna, also external auditory meatus. Then another one is epiglottis, another one is Eustachian tube, also called as auditory tube. Okay, fine. Then what about fibrocartilage? Fibrocartilage is present in all the midline joints. All the midline joints, they have fibrocartilage. The intervertebral disc, pubic symphysis, then sternoclavicular joint, and also remember temporomandibular joint, then glenoid labrum and acetabular labrum, and menisci of knee joint. All are made up of fibrocartilage. Right? Yes. Now coming to the presence or absence of perichondrium. Perichondrium we have studied already. Perichondrium is present in hyaline elastic cartilage only. It is absent in fibrocartilage. Okay. And you know already the type of collagen fibers present in all the three types of cartilages. Type of collagen fibers. Okay, in hyaline cartilage and elastic cartilage, we have type 2 collagen. In fibrocartilage, we have type 1 collagen, isn't it? And also remember, out of these three types of cartilage, which cartilage may undergo ossification or may undergo calcification? Any idea? Yes, hyaline cartilage. Okay, the hyaline cartilage has the tendency to undergo calcification or ossification. Okay, fine. And remember, perichondrium is absent in fibrocartilage, that you know. Not only fibrocartilage, it is also absent in one particular type of hyaline cartilage. Which one? Yes, articular cartilage. Okay, So let's move to the next question. There was one image given like this, okay, given like this, showing the transverse section or cross section of embryo at the level of stomach, developing stomach, okay, cross section of or transverse section of stomach region in the developing embryo, okay, and one ligament has been marked as A, and what is the ligament marked as A? That is the question, okay. So in this diagram, you know the orientation of which is anterior, which is posterior, isn't it? By looking at the vertebral column, you can easily determine this is posterior and this is anterior in this diagram, okay. So this is the anterior abdominal wall, and this is obviously the posterior abdominal wall, isn't it? And you can see the stomach here, okay. And we know in front of stomach we have the liver. Actually, in the question asked in the exam, liver was not given, okay. Liver has not been shown actually, but still, okay. So you are able to see the stomach. In front of stomach we have the liver, and behind the stomach we have the spleen, isn't it? Spleen. So see this diagram again. The same thing I am going to mark. This is anterior, this is posterior, this is the stomach, this is the spleen, okay, and this is the liver, developing liver, okay. So between the anterior abdominal wall and the stomach, what is this peritoneal fold called as? Yes, this is the ventral mesogastrium. Ventral means anterior, ventral mesogastrium. And between the stomach and the posterior abdominal wall, this is the peritoneal fold called as dorsal. Dorsal means posterior. Dorsal mesogastrium, isn't it? Okay. Now, can you tell me which organ develops in the ventral mesogastrium? Yes, it is liver. Liver develops in the ventral mesogastrium. And which organ develops within the dorsal mesogastrium? Yes, it is spleen. Spleen, isn't it? Now the question is, what are the 4 derivatives of ventral mesogastrium and what are the 4 derivatives of dorsal mesogastrium? The 4 derivatives of the ventral mesogastrium can be remembered by this mnemonic lesser fact. Lesser fact. Okay. L is representing, okay, one peritoneal fold between the liver and the stomach, nothing but lesser omentum, okay. And 3 more derivatives of the ventral mesogastrium. FA is representing the falciform ligament, C is coronary ligament, and T is triangular ligament, okay. So these are the 4 triangular ligament. These are the 4 derivatives of ventral mesogastrium, okay. Fine. And can you tell me, out of these 4 derivatives of the ventral mesogastrium, which one is derived from the dorsal part of ventral mesogastrium? Any idea? I think you can understand. In this ventral mesogastrium, this is the ventral part and this is the dorsal part of ventral mesogastrium, okay. So out of these 4, please remember lesser momentum is derived from or developing from which part of the ventral mesogastrium? Yes, dorsal part of ventral mesogastrium. This question has been asked earlier, so take care. This can be asked again, okay. So out of these 4 derivatives of the ventral mesogastrium, the only derivative of the dorsal part of the ventral mesogastrium is lesser momentum. Remaining 3 are derived from this particular part, that is ventral part of ventral mesogastrium, okay. Fine. Now, can you tell me the 4 derivatives of dorsal mesogastrium? 4 derivatives of dorsal mesogastrium. Yes, there is one ligament I am marking now, which is extending between the stomach and the spleen. So what will be the name of this ligament? Yes, gastrosplenic ligament, isn't it? Gastrosplenic ligament. And right now I am marking one ligament that is also derived from the dorsal mesogastrium only, which is extending between spleen and kidney. Okay, namely, yes, it is lino-renal ligament. Lino-renal ligament. Okay, so the four derivatives of the dorsal mesogastrium are: number 1, gastrosplenic ligament; number 2, lino-renal ligament; number 3, gastrophrenic ligament extending from stomach to the diaphragm, gastrophrenic ligament; and another one is a large peritoneal fold hanging from downwards from the greater curvature of the stomach, called as, yes, it is greater omentum. Right? Yes. So this diagram is actually a sagittal section. Okay, the section has gone through above downwards, sagittal section of the developing stomach. Okay, so in this diagram, you know the orientation of which is anterior and which is posterior, isn't it? So the peritoneal fold extending from the anterior abdominal wall to the stomach is the ventral mesogastrium. The peritoneal fold extending from the posterior abdominal wall to the stomach is the dorsal mesogastrium. And here is the development of liver, and here is the development of spleen, isn't it? Okay. Now see this diagram, same sagittal section of the developing abdomen, okay, showing the four derivatives of ventral mesogastrium and four derivatives of dorsal mesogastrium. This is the liver and this is the spleen. Okay, this is the developing stomach. Okay, fine. So we can see the four derivatives of ventral mesogastrium and the four derivatives of dorsal mesogastrium. Okay, once again I repeat, the only derivative of the dorsal part of the ventral mesogastrium is lesser omentum. Okay, fine. So there is something labeled as ligamentum teres. This one, this blue colored structure, ligamentum teres. It is nothing but obliterated left umbilical vein. Okay, ligamentum teres is the obliterated left umbilical vein. Okay, and this is a content of this ligamentum teres or obliterated left umbilical vein is a content of one ligament called as falciform ligament. It is a content of falciform ligament. Fine. So what can be the answer for this question? What will be the answer for this question? Yes, among the four options given here, the only derivative from the ventral mesogastrium is falciform ligament. Okay, because the other three options given here, they are derivatives of dorsal mesogastrium. Okay, and here the structure marked is related to ventral mesogastrium, isn't it? Fine. So the answer for this question is falciform ligament. Fine. Yes, let's move to the next question. Another embryology related question asked was, a newborn presented with the following defect in the lower abdominal wall, and what is the diagnosis? That is the question. Okay. So any idea? Yes, the answer is extropy of bladder. Extropy of bladder, otherwise called as what? Ectopia vesicae. Okay, ectopia vesicae. Okay. So what is the reason for the extropy of the bladder or ectopia vesicae? Yes, this condition is due to defective development of, okay, defective development of what? Lower abdominal wall, lower part of anterior abdominal wall, below umbilicus, infra umbilical part of anterior abdominal wall is defective development. Okay, so what will happen if there is defect in the development of lower part of anterior wall of urinary bladder? Okay, so that what will happen? Yes, the interior of urinary bladder is exposed. Okay, the interior of urinary bladder is exposed. Okay, and there will be dribbling of urine. Okay, so this is what mentioned here by arrow. The urinary bladder is exposed to the exterior through the defect in the anterior abdominal wall, the condition called as extropy of bladder or ectopia vesicae. Fine. Yes, now remember, this ectopia vesicae, otherwise called as bladder extropy, is always associated with another urethral anomaly called as, it is always associated with what? Epispadias, E for E, okay. Epispadias and ectopia vesicae or extropy of bladder, both are always associated congenital anomalies, okay. Epispadias, fine. Okay. Yes. So why not other options? Can you tell me what is omphalocele, what is gastroschisis, what is patent vitalointestinal duct? Actually, 2 years back, this was one of the image-based questions asked in NEET exam. Okay, and the answer for the question was gastroschisis. Okay, the same image has been given. This image was given in NEET PG 2 years back. Okay, so how can you confirm the congenital anomaly, namely gastroschisis? Yes, do you see? This is the umbilicus. This is the location of umbilicus in the anterior midline. Okay, so you can see in the condition called as gastroschisis, there is protrusion of abdominal contents. Okay, there is protrusion of abdominal contents, mainly intestine. Okay, through a defect. Where is the defect in this condition called as gastroschisis? Yes, through a defect. Okay, just to the side of umbilicus. Not exact. The defect is not exactly in the midline. It is just to the side of umbilicus. Usually, the defect will be just to the right side of umbilicus. Okay, usually the defect will be just to the right side of umbilicus, as you are seeing in this diagram. The defect is here. Okay, fine. And what is omphalocele? What is the congenital anomaly called as omphalocele or ex-omphalos? Yes, in this condition, the defect is exactly through the umbilicus only, through the umbilical opening only. Exactly, the defect is in the midline, okay, midline defect. Fine. Yes, what is the reason, embryological basis for omphalocele? You know, during the sixth week of development, there is one natural, normal phenomena called as physiological umbilical hernia. Okay, so, and the physiological umbilical hernia will get reduced during the 10th week of development. Okay, physiological umbilical herniation occurs during 6th week, and the reduction of this hernia usually occurs during the 10th week of development. Okay, if there is failure of reduction, okay, if there is failure of reduction of abdominal contents, okay, if there is failure of reduction of abdominal contents during the 10th week, it will result in the congenital anomaly called as omphalocele or ex-omphalos. Okay, so please take care. What is the embryological basis for the gastroschisis and what is the embryological reason behind the omphalocele? Okay, fine. And one more option given was patent vitalointestinal duct, isn't it? Okay, so during fetal life, there is one embryological communication between the yolk sac and the intestine called as vitalointestinal duct, VID. Okay, normally the entire vitalointestinal duct will disappear normally. Okay, but okay, there may be abnormality in the vitalointestinal duct. For example, if the proximal part of the vitalointestinal duct is persisting, what is that congenital anomaly called as? Yes, it is called as Meckel's diverticulum. Okay, MD. Meckel's diverticulum is due to proximal persistence of the vitalointestinal duct. Okay, actually this is the most common congenital anomaly of GIT. Most common congenital anomaly of gastrointestinal tract is Meckel's diverticulum. Fine. And actually this particular part of the midgut is ileum. Okay, ileum. Fine. And what is this second image showing? Yes, if the entire vitalointestinal duct is persisting, okay, if the entire vitalointestinal duct is persisting, it will be called as what? Yes, it is called as fistula. It is called as vitelline fistula, otherwise called as otherwise called as umbilical fistula, umbilical fecal fistula, because the feces will be coming out through the umbilicus because of the communication between the ileum and umbilicus. Okay. So vitelline fistula, otherwise called as umbilical fecal fistula, is due to entire persistence of the vitelo-intestinal duct. Fine. Okay. Now, this is what we have studied. The vitelline fistula or umbilical fecal fistula is the entire persistence of the VID. Okay. And what is the condition called as umbilical sinus? Yes, this congenital anomaly is due to persistence of only the distal part of VID. Only the distal part of vitelo-intestinal duct is persisting. It will be called as umbilical sinus. So sinus means only distal part of VID is persisting. Okay, fine. And if only the middle part, proximal part and the distal part of VID is obliterating, but the middle part, only middle part of VID is persisting, it will be called as what? Vitelline cyst. Okay. So please take care. Any of this may be asked in the future PG entrance exam, maybe NEET or NEET, whatever. So make sure you can identify the Meckel's diverticulum, vitelline fistula or umbilical fecal fistula, umbilical sinus, and vitelline cyst. Okay. Yes, let's move to the next question asked. A 60-year-old man came to OPD with the complaints of slurring of speech, inability to close his right eye. On examination, the patient was unable to blow his mouth, and there was deviation of angle of mouth. All these clinical features are suggestive of injury to which of the following cranial nerves? Okay, so what is the answer? Yes, all these clinical features are suggestive of what? Bell's palsy. Okay, you know Bell's palsy is a lower motor neuron, LMN, lower motor neuron type of facial nerve palsy, isn't it? Seventh cranial nerve, facial nerve palsy, isn't it? So the answer is facial nerve palsy, seventh nerve palsy. Okay, fine. So this is the diagram showing the clinical features of Bell's palsy, which is due to facial nerve injury, seventh nerve injury. Okay. So in facial nerve injury, that is in Bell's palsy, all the muscles of facial expression will undergo paralysis, isn't it? So the clinical features of Bell's palsy are due to paralysis of all the muscles of facial expression. Okay, so what will be the clinical features? There will be loss of wrinkles of forehead, okay, due to paralysis of frontalis muscle, okay, one of the muscles of facial expression, okay, frontalis muscle paralysis, okay, and inability to close eyes. What is the reason? Yes, inability to close eyes is because of paralysis of one muscle under the eye, which will help for closure of eye, called as orbicularis oculi, isn't it? Orbicularis oculi palsy. Okay, and there will be overflowing of tears on cheek, called as epipora. This is also due to paralysis of which muscle only? Orbicularis oculi palsy. Okay, and some other features are there will be loss of nasolabial fold. There will be drooling of saliva from the angle of the mouth. Okay, and there will be asymmetry of the face. The face will be pulled to the normal side or healthy side. Okay. So these are the various clinical features of Bell's palsy. And one more thing we can add here, okay, is there will be accumulation of food in the vestibule of mouth. Okay. The patient cannot masticate properly. So because of accumulation of food in the vestibule of mouth. Can you tell me this is due to paralysis of which muscle? Yes, accumulation of food in the vestibule of mouth is due to paralysis of buccinator muscle, due to buccinator palsy. Okay. So please take care of the various clinical features of Bell's palsy. Fine. And now, other options. What will be the clinical features of third nerve palsy? You know, the third nerve is oculomotor nerve, which is the main nerve supplying the extraocular muscles and also the two intrinsic muscles. Okay. So if there is injury to the oculomotor nerve, What will be the clinical features? You know the short form for remembering the clinical features of oculomotor nerve palsy, isn't it? P, PD, PDO, like that. Okay. So what is P representing? Yes, P is representing ptosis, that is drooping of upper eyelid. Okay. If there is oculomotor nerve injury, third nerve injury, there will be complete ptosis, complete drooping of upper eyelid. Okay. What is PD? Yes, PD is representing the dilatation of pupil dilatation. That is, okay, pupil dilatation, that is mydriasis. Okay. Pupil dilated and fixed. Pupil will be dilated and fixed. Okay. That means what? Fixed pupil means what? Yes. There is no accommodation. Accommodation will be loss of accommodation process. Okay. Fine. And what is PDO? Yes. Pupil is deviated or moving downwards, down and out, downward and outward movement of pupil, or you can say eyeball. Okay, fine. These are the clinical features of oculomotor nerve injury. Okay, and other than this, there will be loss of pupillary reflex. There will be loss of pupillary light reflex, because the efferent for the pupillary light reflex is oculomotor nerve, isn't it? Fine. So these are the clinical features of oculomotor nerve palsy. Fine. And one more thing is, what will be the clinical features of hypoglossal nerve palsy, hypoglossal nerve injury, or hypoglossal nerve palsy? 12th nerve, hypoglossal nerve. Yes. In hypoglossal nerve injury, there will be paralysis of one muscle of the tongue, namely genioglossus. Okay. So in hypoglossal nerve injury, due to paralysis of genioglossus muscle, okay, genioglossus muscle will get paralyzed. Okay. So when the patient is asked to protrude the tongue, okay, protrude the tongue, when you ask the patient to protrude the tongue will be deviating to which side? Yes, deviation of tongue to the same side or opposite side? That's my question. Yes, deviation of tongue to the same side, affected side, same side or affected side or paralyzed side. Okay, not to the healthy side. If there is, for example, if there is injury to the right hypoglossal nerve, the right genioglossus will get paralyzed. Same side genioglossus muscle will undergo paralysis. So the deviation of tongue will be to which side? Right side, same side. Okay. Yes. Fine. Let's move to the next question. One among the 3 ear ossicles was given. Okay. And image was given. So the question was asked to identify the bone given in the below image. Okay. So any idea about the ear ossicle you are seeing here? Yes, is it malleus or incus? Yes, it is incus. Okay, incus. Okay, fine. So how to identify the ear ossicles? You know, totally we have 3 pairs of ear ossicles present in the middle ear, both the right and left middle ear. We have 3 pairs of ear ossicles. And you know the peculiarity of all the 3 ear ossicles, right? What? They are of adult size at the time of birth itself. Okay, all the 3 ear ossicles, they are of adult size at the time of birth itself. Okay, fine. And out of these 3 ear ossicles present in the middle ear, remember the arrangement from lateral to medial is, this is the malleus. You are seeing here is malleus. This is the incus and this is the stapes. Okay. So in both the ears, middle ear, from lateral to medial, the arrangement of 3 ear ossicles will be malleus, then incus, then stapes, from lateral to medial. Okay. Starting from tympanic membrane towards the inner ear. Okay. Fine. Remember this order from lateral to medial, malleus, incus, stapes. Okay. So now the question arises, how to identify the individual ear ossicles. Okay. So in this diagram, the first one is malleus. The second one, this one is incus, which has been asked in the exam, and another one is stapes. So you can see the malleus will be having certain parts like head of malleus, neck of malleus, the constricted part below the head is neck. Okay. Then it has two processes. One is anterior process, another one is lateral process, and also it contains handle. Okay. So the malleus consists of all these various parts like head of malleus, neck of malleus, then anterior process, then lateral process, then handle of malleus. Okay. Handle of malleus. Okay. And obviously, you know, the head of malleus contains one facet, one particular area for articulation with the incus. Fine. So if you see in the image all these parts like head, neck, and the two processes and the handle, you can confirm the bone as malleus. Okay. How to identify the incus? Yes, incus contains three parts. One is body of incus, and the two projections. One short projection called as short limb or short process, and one long projection called as long process. Okay, long process or long limb. Okay, fine. And this is the particular area of the incus which articulates with the malleus bone. Okay, fine. And coming to the stapes, how will you identify the stapes? Stapes can be easily identified, isn't it? Because of the presence of head of stapes and the two limbs through which the head will be attached to the base. Base, otherwise called as foot plate of stapes. The base of stapes, this is the base of stapes, which can be otherwise called as foot plate of stapes. Okay, which will be attached to the cochlea, to the fenestra vestibuli by annular ligament, isn't it? Fine. So if you know the various parts of the ear ossicles, we can easily identify. Actually, there is some difficulty in understanding, differentiating these two ear ossicles, malleus and incus. That is true. Okay. So now I hope you will be clear. By looking at the various bony parts, we can determine whether it is malleus or incus. Stapes, there is no difficulty because of the presence of base or foot plate. Okay. Yes. Please try to identify all these bony projections to identify the various ear ossicles. Okay. So see here, this is the joint formed between malleus and incus. That is called as incudo-malleolar joint. What type of joint is incudo-malleolar joint? Yes, incudo-malleolar joint is a saddle type of synovial joint. Saddle type of synovial joint. Okay. And what is the joint formed here? What is the joint formed here at the area I am marking now between the incus and stapes? Yes, this is the incudo-stapedial joint. What type of joint is incudo-stapedial joint? Yes, it is also synovial joint only, but what type of synovial joint is incudo-stapedial? Yes, it is ball and socket type of synovial joint. Okay. So both the joints formed between the three ear ossicles, namely incudo-malleolar joint, incudo-stapedial joint, both are synovial joints only. So please be clear which is saddle type and which is ball and socket type of synovial joint. Okay. So this is the foot plate of stapes, which will be articulating with which will be attached to the fenestra vestibuli of inner ear through the annular ligament. Okay, fine. So this is the malleus, this is the incus, and this is the stapes. So be clear how to identify the ear ossicles. Fine. So let's move to the next question. There was one image like this. Identify the structure marked by arrow in the given histological image. Okay. Since the four options were not properly recalled, I have not included the options. Okay. So the given histological image belongs to, yes, it is the pancreas. Okay. This is the histological image of pancreas. Okay. And particular area marked by arrow is nothing but islets of Langerhans, isn't it? Islets of Langerhans. So how to identify the islets of Langerhans? Yes, they are lightly stained areas. Okay, islets of Langerhans are lightly stained areas of the pancreas. Okay, and what are these darkly stained areas of the pancreas called as? Yes, those are the exocrine part of pancreas called as acini, pancreatic acini. Okay, So the pancreatic acini they are the exocrine part of pancreas, exocrine part involved in the secretion of pancreatic juice. Okay, pancreatic acini. So pancreatic acini, as you see in this diagram, they are darkly stained. They are darkly stained areas. In contrast to the islets of Langerhans, which are lightly stained areas, isn't it? Okay. And one more thing that can be asked is the pancreatic acini. They will be having some ducts called as intercalated ducts will be there. Intercalated ducts. Okay. So remember the intercalated ducts of the pancreatic acini, they are lined by particular cells called as centroacinar cells. This question has been asked in the previous exams. Centroacinar cells are present in which of the following organ? What is the answer? Yes, centroacinar cells are present in pancreas, which are lining the intercalated ducts. Okay. So islets of Langerhans, they are lightly stained areas. You know, those are the endocrine part of pancreas, which contain alpha cells, beta cells, delta cells, which will secrete the glucagon, insulin, somatostatin, all these hormones respectively. Okay, fine. So other than this, one question was asked related to the interior of the base of the skull. Okay, actually, no one was able to recall the exact case scenario. So that's why I have not included that question. Okay. But there was one question related to the base of skull, interior of base of skull, the various foramina, the nerves passing through the some foramina like superior orbital fissure, foramen ovale, like that, optic canal, like that. One question was asked. Okay. Since the question was not properly recalled, I have not included that. Okay. So that's the end of the anatomy recall session of NEET PG 2022. Thank you all.